So we're going to do a little bit of a talk on our role here as mid-levels at Fertility Institute of Hawaii, but we're going to introduce ourselves first. So I'm going to start. My name is Tricia. I am a physician assistant at FIH. I graduated in 2008, that long ago, from PA school in Pennsylvania. I initially went into OBGYN for about 3 years, and I loved it. I did do a short little transition to urgent care for 2 years, but quickly realized that women's health was where my heart was. I then started working here at FIH in 2013, so going on 9 years that I've been here. I did not do any fertility before coming here, so everything that I've learned has been from Dr. Frattarelli and then later on Dr. Karmon. And I have a passion for what I do, and I mean it when I say I am happy to come to work every single day.
Thank you, Tricia. I'll go next. My name is Anna. I am a nurse practitioner, and I've discovered my passion for fertility also a long time ago, in about 2008. That's when I started working as an embryologist at one of the fertility clinics and worked there for 4 years. After that, I decided that I want more direct patient care. And so I decided to pursue a nurse practitioner degree. And while I was in graduate school, I also worked as a fertility coordinator for 2 years for another fertility center. So I've got to try another hat on in the fertility business. And after graduating with my master's degree, I joined the Fertility Institute of Hawaii team. And I've been here for 6 years. I'm going to be going on 7 in December. Needless to say, I do love to come to work as well every day. We have a great team of providers. Everybody's very dedicated. Everybody loves what they're doing. So yes, we're very happy to see when we're helping patients.
All right. Thank you, Anna. I'll go next. My name is Lyndsey Smith. I'm also a nurse practitioner. I graduated from Creighton University with my nursing degree back in 2007, and then worked at the med center there for a little bit. Then I decided, okay, maybe I should do something more. So then I got my master's at University of Nebraska Medical Center in 2013. After that, I decided it was time to come home, back to Hawaii, so that I could be back home with family and friends. So I started off as a women's health nurse practitioner at other clinics, and then joined Fertility Institute of Hawaii in 2018, and has never been happier to come to work. Like Anna and Tricia mentioned, it really is, very fulfilling, and I really enjoy the patients and the coworkers that I have here. And that's, I've been here since 2018, going on 3 years now.
Thank you, Lyndsey. So my name is Jay. I'm one of the nurse practitioners here as well. I'm actually a newest addition to the provider team. I joined as a provider here at FIH last year in October, but prior to that, I've been an FIH family for about a little over 6 years, being an IVF coordinator and a nurse. And I got to really work with a lot of the patients who are doing in vitro fertilization cycle, which is why I felt like I was very passionate about this field. And I decided to go back to school for an advanced degree to join as a nurse practitioner eventually. And since I've started, I've really enjoyed the process of being in the treatment and, deciding on patient protocols. And I do feel like I'm very privileged and grateful to be able to be part of the patient's journey of family building process here in FIH.
Thanks, Jay. So I think we're going to each try to take a little bit of time to talk about a couple different categories. So I'm going to kind of start with what we do as quote unquote mid-level providers here at FIH. So that includes myself and nurse practitioners, and some people don't like that title, but I don't think we mind it, so we'll use it. So, you know, what we do here at the practice is very important. We actually do quite a lot here at FIH. We start by seeing all of the new patients. Every new patient that's seen is seen by one of us. We, during that appointment, are able to spend a lot of time with our patients because we have more time. And so we're allotted an hour with our patients to be able to get their history. We go through previous treatment cycles with them. We get all of their history, including like their GYN history, surgeries, medications they're on, and then also their personal history of what they've gone through to get to this point. So a lot of our patients have extensive history that, you know, needs to be gone through so that we make sure we're not missing anything. We then develop a plan for all of our patients. This will include things like testing that needs to be done, and then that plan will ultimately be reviewed by one of the physicians, whichever physician they have been allotted. So Dr. Frattarelli, Dr. Karmon, Dr. Goulet. And then that physician will review the plan. If there's any changes, they will let us know. And then sometimes the doctor will see them that day, and sometimes they won't, depending on availability. Either way, we start with any kind of testing that needs to be done. A lot of the time, the testing is done by ourselves. So we'll order lab work, we'll interpret that lab work. If there's anything that comes back abnormal, and additional testing needs to be ordered because of it, so any more imaging or further testing like lab work, we will then order that. One of the big things that we do is saline ultrasounds. So these are to evaluate the cavity of the uterus as the baby needs to grow. And it's a procedure that's done in our office, and we will perform all of those. And then when all of the workup is done, then the patient will see the doctor for a follow-up visit and discuss all of the testing that we ordered and went over, and come up with their best treatment plan. We also do other types of ultrasounds here. So we will do cycle determination ultrasounds where we find out where the patient is in their cycle. We do ultrasounds that will allow us to know why a patient might not be getting their period. And we also do OB scans, so early pregnancy ultrasounds for all of our patients. And then one of our main jobs here as mid-level providers is doing ovulation induction cycles. And we're going to kind of go over that in a little bit more detail because it's one of our main things that we do here. So I will pass it on to Tricia to talk next.
So as mid-level providers, we see a lot of ovulation induction patients who are doing either prime intercourse or doing the IUI insemination cycles. But we do also have three physicians here, Dr. Frattarelli, Dr. Karmon, and Dr. Goulet, who supervises us and reviews all the plans. And we're able to ask questions if we do have any physicians that are also going to be coming into ultrasound scans if we need them to review at the time, like real time with ultrasounds. And as a team here, we kind of work as a team, all of us, both physicians and the providers, mid-level providers, and we're going to be reviewing the plan together and coming up with treatment options as well.
All right. Well, I can talk a little bit about the ovulation induction. Typically, if your evaluation was fairly normal, so there's not a bilateral fallopian tube blockage or significant semen analysis abnormality, like a really, really low count. So typically, if everything sort of checks out okay, you're going to start with ovulation induction cycles. Ovulation induction cycle is a minimally invasive treatment. It's sort of in between doing nothing and having timed intercourse at home, going to all the way doing IVF, in vitro fertilization. We usually recommend doing 3 to 4 ovulation induction cycles to see if they may work. And ovulation induction is what it is, making your ovaries ovulate. Some patients may be already ovulating naturally, and they might say, well, why do I need to do ovulation? In studies, even if you are ovulating on your own with the use of medication, um, the pregnancy rates are still higher, and that's because we are monitoring the cycle. We are uh, determining when you're going to ovulate and helping you ovulate with a trigger shot. And then we are also placing the sperm at the right time into the uterus. For patients who are not ovulating on their own, let's say with like polycystic ovarian syndrome, ovulation induction cycles help to get the ovaries to start ovulating. Um, so, what are the typical medications that we use? There are two oral medications. One is Clomid, probably most well known. Another one is Femara, or it's also called letrozole. So, those are the two oral medications. Usually, you would take them for 5 days, occasionally for 8, depending what your diagnosis is. And then we bring you back to see how your ovaries are responding to the stimulation with the medication. We monitor you with ultrasounds, right? So we are looking for a follicle that starts to mature and grow. There is a certain size that we're looking for. We want to see a follicle that's about 17 to 18 millimeters. And that's what tells us that the egg inside is going to be mature. Um, that's when we would want to schedule your trigger shot administration. So when you were, 16, 17, 18 or above. Um, After the trigger shot, we are going to schedule either, you have timed intercourse at home within 24 to 36 hours, usually 24 hours, or we're going to schedule your intrauterine insemination or an IUI, which also can be scheduled within 24 to 36 and sometimes 40 hours. It is a window. Um, the other medication that we use for ovulation inductions is injectable gonadotropins. You might have heard the name Follistim, Gonalef, Manipure. It's a subcutaneous injection, usually done into the tummy, and you do them every day until your follicle is of the right size, about 17 to 18 millimeters. Now, these medications are very expensive, and a lot of times insurance companies will require you to do some cycles with oral medications prior to covering injectable gonadotropins. But I just wanted to mention them because for some patients, that's also an option, and they kind of want to jump right in and do injectable gonadotropins right away. The chance of pregnancy with oral medications compared to injectable medications is slightly higher, but not, of course, nearly as much higher as with in vitro fertilization. But it's still a good option for some patients. Um, the disadvantage, of course, is that you have to take a daily injection, and sometimes you can have a little bit of irritation at the site of administration, or you may bruise a little bit. But overall, it's not too much of an inconvenience. Now, when we administer the trigger shot, we will most likely schedule an intrauterine insemination. So, what is an intrauterine insemination? It is a very simple procedure. I usually compare it to a pap smear. It's almost like a pap smear. We will use a speculum to find your cervix, and then we use a small, flexible, narrow catheter. It is the same catheter that we use for saline infused sonograms, but we infuse a very small amount of fluid. It's literally zero point 0.5 milliliters. So it doesn't cause as much discomfort as for some people a saline test may cause. And we deposit the sperm at the fundus of the uterus, so right at the very top by the fallopian tubes, delivering the specimen as close to where it needs to be, close to the egg as possible. It may cause some cramping sometimes, it may cause some spotting, but usually the discomfort is minimal. And you can always take some Tylenol after the procedure to reduce the cramping. We usually have you lay down for 10 minutes. For some patients, we will get some blood work done as well after the IUI. But then there's not really any significant physical restrictions after. And you can follow it with timed intercourse as well. Um, yes, so that would be sort of the short summary or outlook on the ovulation induction. And I'm gonna pass it on to Lyndsey, right?
Yes, yes. Thank you for the ovulation induction 101, Anna. So usually if you are doing a monitored ovulation induction cycle, typically have you come in between, as Anna's mentioned, early in the cycle so we can do an ultrasound and blood work. The blood work is helpful because sometimes we may see something on an ultrasound like a simple cyst that is a little bit larger in size. With the blood work, we can tell, okay, is this cyst producing any type of hormone, mainly estrogen? If that is the case, then we might recommend repeating ultrasound before starting medication, or even resting that cycle until you get another period and we'll start the following cycle. When you do the injectable medication for ovulation induction, we always do blood work because we monitor those hormone levels a lot closer. We can increase the dose or decrease the dose depending on that estrogen level. We can also tell if you're ovulating on your own when we do that blood work. Um, we always, we definitely review all labs with our physicians. If there is any change in plan, we always call our patients and let them know. Typically, we don't call unless something is going on, but we are more than happy to go over labs with patients at any time.
That's kind of just an overview of what, we all do here at FIH. There's a lot of behind the scenes work too, obviously, reviewing lab work and helping in any way for our physicians, because that's, always our goal is to make their life a little bit easier so they can dedicate more time to their patients. So there's some of that too, and, we're happy to do it and happy to take care of our patients. And if you guys ever have questions or concerns, you can always ask us. We're very available. I think that's it. Anything else, ladies?
Any questions?
No. Good. Alrighty. Thanks for
Thank
tuning
you.
in.